to have today Dr. Dan Sofer, that is someone that I admire a lot and knows a lot about triglycerides and also a good friend. He will be talking about triglycerides as a bystander, target, or smoking gun. So Dr. Sofer earned his BA and MD from the University of Pennsylvania, where he also completed his internal medicine residency at the hospital of the University of Pennsylvania. And he has practiced his entire career since then there. He's a clinical lipid specialist with a focus on preventive cardiovascular medicine and also general internal medicine. He's a full-time clinician and clinical associate professor of medicine at the Division of General Internal Medicine and the Division of Translational Medicine and Human Genetics at Penn. He is the co-director of the Preventive Cardiology Fellowship at Pennsylvania Hospital and the director of the Foundations of Culinary Medicine course as well. He is the president-elect of the National Lipid Association and a past president of the Northeast chapter of the NLA. He also has been the co-editor for the NLA journal Lipid Spin and an associate editor of the Journal of Clinical Lipidology. And he's also the co-director and lecturer of the Foundations of Lipidology course of the NLA. That is a great course that I recommend to everyone. So thank you so much for being with us. I'm very excited about your lecture.
Thank you, Leandro. Appreciate it. Thanks for that. I would have edited that down to be a much shorter bio, but thanks for going through all that. Appreciate all that. These are my contacts and my affiliations, so please feel free to reach out if you have any questions from today's lecture, or if you have any interest in being more involved with the National Lipid Association or learning more about lipidology in general. These are my disclosures. I wanted to start out just by talking about a patient. I actually just saw a patient this morning and I said, oh, I'm about to give a lecture and you have all of these same characteristics. I could have just talked about you. But someone who I think you'll recognize in your regular practice, this patient is a 36-year-old office worker with hypertriglyceridemia. She has no past medical history or surgical history. She's basically healthy. She's G2, P2. She has normal menses and she's on OCPs. She has no prior gestational diabetes or hypertension. And the only medicine she takes is the oral contraceptives. There's no heart disease in her family, no diabetes. Her BMI is 28, so not normal. She's overweight, but she has normal vital signs and really nothing extraordinary on physical examination. There's her laboratory tests are shown here. Her total cholesterol is 200 milligrams per deciliter. In fact, all these are in milligrams per deciliter. Triglycerides are 750, HDL cholesterol 35, non-HDL cholesterol is 165. And I wonder how many of you are used to ordering ApoB, but this is, and we'll talk about why ordering ApoB in a patient like this is important, but her ApoB level is 100 milligrams per deciliter, where anything over 120 milligrams per deciliter would be a sort of a red flag for concern. Her glucose is 80 and her A1C is 5.5%. And you can see her transaminases, her uric acid, TSH, and a urinalysis are all normal. So we'll be coming back to her to think about things as we go forward talking about triglycerides. But, you know, I highlighted her triglyceride level there, clearly abnormal. So the real questions you have clinically are, why does she have high triglycerides? Will this ever harm her? And if so, how? And then if it will harm her, should this be treated, and how should we be treating her? So the objectives from today's program is ultimately so that we can answer those questions well. And in order to do that, I think it makes sense to review triglycerides and lipoprotein physiology. We'll consider the impact of hypertriglyceridemia on health and disease, and update the guidelines for the treatment of hypertriglyceridemia, and focusing on whether we should be treating triglycerides or the lipoproteins that carry triglycerides. So some of the key points, if you have to run and you don't need to pay attention to anything else, is just a reminder that hypertriglyceridemia is causally associated with atherosclerotic cardiovascular disease and acute pancreatitis. That hypertriglyceridemia is the consequence of combined impact from genes and the environment, and that it's rarely monogenic. But in a lipid clinic, we do get to see some of these patients, and every once in a while you'll run across the monogenic causes also. Our treatments right now are focused on reducing the main worst outcomes, acute pancreatitis and ASCVD, and that in general, to reduce acute pancreatitis, we're talking about lifestyle modification and specifically triglyceride lowering. Whereas for ASCVD, it's risk factor modification, and it's a statin-based ApoB lowering regimen. And additionally, the use of icosapentaenoic acid or EPA as a tool for reducing cardiovascular risk. I'm surrounded by lipids at all times, and I sometimes forget that there's a lot of different nomenclature that's overlapping and confusing when you're outside this realm. But I wanted to sort of pull that in and summarize that, because if you're not thinking about this on a regular basis, it's very easy to jumble it all together. So patients who have hyperlipidemia, you can classify them in a lot of different ways. So first off, there's the lipids, right? So you can have high cholesterol, or you can have high triglycerides, or you can have both, like in a combined pattern. But that's just descriptive regarding the lipids. However, if you really want to understand what's going on, you have to understand which lipoprotein is abnormal that's carrying the lipids, because they have different implications for prognosis, different implications for treatment, and different implications for response to therapy. So knowing whether somebody has high levels of LDL versus VLDL versus chylomicrons or combinations matters. Also, we can classify our patients based upon syndromes. So a syndrome is when you have a combination of factors that looks like it's going to be in a particular pattern, and that you can have an expectation for prognosis based upon the syndrome. Of course, we have acronyms for all of the important high triglyceride syndromes and high cholesterol syndromes. So FH is familial hypercholesterolemia. We also, familial combined hyperlipidemia, familial hypertriglyceridemia, and there's some others that are listed here. And knowing the specific syndrome impacts how we treat the patient and is very useful, but not super easy to make these diagnoses. And then, of course, we're in the molecular era now, too. So we have access to genetic testing, and it's very easy to think of patients according to what gene they have that's abnormal. But of course, these are just the genes that we know have an impact. Sometimes we have two patients with the exact same genotype, but they have different phenotypes, and understanding that there's some complex interactions between the genotype and the environment, and then just pure chance. So you can't always predict outcomes simply on the basis of genotypes, but they should be part of the picture. So all of these things need to be factored in when we're seeing our patients, and are useful descriptors to help with the care of our patients in best way possible. I won't dive into the biochemistry too much, but we will talk about mechanisms. And just a reminder that when we're talking about triglycerides, we're talking about this molecule here. So just as a reminder, triglycerides are an energy molecule. Their purpose, their design is as a very efficient tool for carrying high energy bonds from one part of the body to another part of the body. And the high energy bonds are carried on this triglyceride molecule. So you have a 3-carbon glycerol backbone with a fatty acid moiety esterified to each of the carbons. And you're able to yield a great deal of energy from the normal metabolism of those fatty acids. And triglycerides are a terrific carrier of high energy bonds. And their principal carriage is that of fatty acids. And these are just 3 sort of examples of different fatty acids. Focusing on the difference between them is the presence of the double bond. So at the top, you see palmitic acid, which is just a typical saturated fatty acid in its linear form. Oleic acid is a monounsaturated fatty acid. It's called that because it has a single double bond. And what is not shown here is that when you have a single double bond, it creates a kink in the chain. And so instead of distributing itself in a linear fashion, it actually has a kinked characteristic. And what that means is that if you have a lot of monounsaturated fatty acids, they don't line up in a nice linear manner. They don't pack together very closely. And so at room temperature, they tend to be liquid as opposed to solid saturated fatty acids. One of the exceptions when you have mono or polyunsaturated fatty acids is that they can have trans configuration as opposed to the cis configuration. And so when they have a trans configuration, they actually do have a more linear structure. And so they actually tend to be more solid at room temperature. That's their principal characteristic. But all of these fatty acids carry a lot of energy in their bonds, and that's why they're energy molecules. So the normal triglycerides in the population is somewhere anything less than 150 milligrams per deciliter. And we know that in the US population on average, that about 25% of the population has levels above that. There are differences between sexes. So men tend to have higher triglycerides than women. There's different ethnic differences and different racial differences, but on average, about 25% of the population has high triglyceride levels. There's been some change since that 2007 NHANES data came out, and you can see that the triglyceride levels on average have come down in the subsequent decade. Now, this is also from NHANES, and I've talked to a bunch of my colleagues in lipidology to get their take on what do you think is happening from 2007 to 2017 with regards to triglycerides, because everybody on the planet seems to be getting more obese, and you would expect to see more triglycerides. There's way more diabetes than we've ever seen. You would expect to see higher triglycerides. So how is it that the average triglyceride has come down in that time frame? And I can tell you, I've talked to some pretty smart lipidologists about this, and their basic answer is, I don't know. They don't know. I don't even have a good hypothesis, frankly, but triglycerides have come down in that last decade. So we'll see what the subsequent NHANES will show us about the next round of data, but they've come down, and it's surprising. This is a table from one of our references recently. We looked at, what you call high triglycerides varies. The nomenclature varies depending on what guideline you're following. So at the top, you have the European guideline. At the bottom, you have the Endocrine Society. But I highlighted the 2018 AHA-ACC multi-society guideline on the management of blood cholesterol. That's the US guideline on lipids. And you can see that anytime triglycerides are less than 175 milligrams per deciliter, we think of that as being a normal triglyceride, and anything over 500 is considered to be, severely elevated. So it's the mild to moderate that are in that 175 to 500 range. When you have high triglycerides, you are going to have high triglycerides because of acquired or environmental triggers or inherited syndromes. Or maybe not even syndromes, but just inherited characteristics. And the types of environmental changes you can see here are myriad, from anywhere from what you're eating and drinking to what your metabolic status is or your medical status. I stole this analogy from a colleague of mine who's a genetic counselor that we had done a program together. Katie Auger had shared this. The mason jar represents the phenotype, and the size of the mason jar represents the severity, or the prevalence of the phenotype. So if you think about the small mason jar representing the rare, infrequent causes of the severe hypertriglyceridemia phenotype as being caused by monogenic disorders, the yellow circle is the gene. So single gene mutations that have a major impact can cause a severe hypertriglyceridemia. And those individuals, the environmental factors tend to have a smaller impact, but some impact. So it's not that there's no impact, it's just less than you'd expect compared to the much more common phenomena of the severe phenotype being caused by multiple genes overlapping, or the polygenic causes of the phenotype. And in those patients who have polygenic cause of high triglycerides, we know that the environmental impact is much greater. So not only is the mason jar bigger because it's the far more common cause, but the blue squares represent the much greater impact on the phenotype. There's lots of genes that are associated with hypertriglyceridemia. This is a 2013 paper, and I think the number has grown even since then, but at least 45 loci are associated with specific abnormalities that can affect the triglyceride phenotype. Some of the genes seem to affect only triglycerides. Some seem to affect cholesterol levels in HDL and in LDL. And, so we know there's a lot of genes that are affecting triglycerides. If you have looked into anything regarding lipids and genetics, you may know the name Rob Hegley. Rob Hegley is probably the world's foremost expert on the genetics of dyslipidemia. And Rob has stated pretty emphatically that most cases of hypertriglyceridemia are felt to be polygenic with strong influence by environmental factors. And he was really the senior author on the National Lipid Association paper on genetics and management, genetic management for dyslipidemia. And he actually graded it a class 3 recommendation to do genetic testing for patients with high triglycerides on the basis of this statement. He did give it a class 2B recommendation, meaning reasonable to do under circumstances where you expect a monogenic disorder is present. But even in those severe cases, the impact of measuring the genetics is not critical for the management of the patient, is what the final conclusions were. Just as a reminder, triglycerides and cholesterol are fats, they're lipids, so they can't be circulating in blood without some sort of carriage mechanism because they don't dissolve in blood. And so, of course, they're carried by lipoproteins. This is a famous figure from John Goffman's Berkeley lab from the 1960s. That group was the first to characterize the lipoproteins as distinct entities responsible for the carriage of lipids, and separated them out according to partly by size, as shown as the x-axis of diameter from smallest to largest from left to right, and by density, and from the most buoyant or least dense at the top to the most dense at the bottom. So HDL particles are the smallest, densest particles down in the bottom left, and chylomicrons are the most massive, most buoyant, least dense particles at the top right. And you can see that the diameter can vary between them, but you'll notice at the bottom that once you get past VLDL particles, that there's a big jump in size. So chylomicrons are truly massive. And in fact, when someone has chylomicronemia, that these chylomicrons are in high concentration in the serum, they're actually change the refractory characteristics of light. And this serum is actually opaque because chylomicrons are so large. And that when you get to excesses in the other particles, you tend to have either opalescent or translucent serum, even when those other particles are in high concentration. I also highlighted that 70 nanometer because we'll talk about that as we talk about the physiology of atherosclerosis. But 70 nanometer seems to be the threshold below which particles can enter into the subendothelial space to promote atherosclerosis, that particles that are larger than 70 nanometers are just too large to penetrate into the subendothelium. So chylomicrons do not directly impact atherosclerosis. Everything to the right of the red bar are considered triglyceride-rich lipoproteins. So LDL, LPA, and HDL particles tend to be triglyceride-poor particles, whereas all of the other lipoproteins are triglyceride-rich. So thinking about our patient with the triglycerides of 750, is she at risk for atherosclerosis, or is she at risk for acute pancreatitis based upon the information we have? Not sure we have enough information. So I really do like to think about the lipoproteins. And so when you have a lipid profile, you don't really have access to knowing what the lipoprotein status is. But we know that lipoproteins can be characterized by their lipid content and the expected ratio of triglycerides to cholesterol. So in our patients who have low levels of triglycerides, we know that all of the cholesterol in the circulation is either found in HDL particles or in LDL particles, but all of the other triglyceride-rich lipoproteins are not really contributing much unless you have high levels of triglycerides. So the blue indicates the triglycerides. So if your patient has triglycerides above 150 or 175 milligrams per deciliter, then those other lipoproteins are going to be found in the circulation. And the relative impact on atherogenicity is estimated not by the triglyceride content, but by the cholesterol content. And so instead of focusing on just the LDL cholesterol, which may not reflect all that, you should focus on the non-HDL cholesterol. And non-HDL cholesterol is represented by the total cholesterol minus the HDL cholesterol. So I think that's something that, some people use regularly and pay attention to, but it's lost a lot of its attention in the last 5 to 10 years. In the last decade, we were talking a lot about non-HDL cholesterol, and it's not getting very much attention these days, but it still should be considered as the principal cholesterol level that you're interested in when you're trying to determine atherogenic potential. So I'm really going to jump into the Wayback Machine here. And if any of you are breaking out in a cold sweat when you see the Friedrichsen-Levi-Lees classification, it's because you probably had to memorize it for some test, and you may not have thought about it much in the interim. But I can tell you that, I still find it somewhat helpful in our patients, at least in terms of how I structure which lipoprotein is in excess. And so you may recall from this classification system that we don't use very much anymore, that all of the hyperlipoproteinemias that were identified by this group in the 1960s were characterized by high triglycerides, except for type 2A. So all of the others have high triglycerides. And the difference between them is which lipoprotein level is in excess. So all of the different classifications have either one lipoprotein level in excess or two. So for example, type 1 patients have just chylomicron excess, whereas type 5 have chylomicrons and VLDL. So two different lipoproteins are in excess. And it has implications because remember, the VLDL particles carry cholesterol. And they carry more cholesterol than chylomicrons. So you'll see higher levels of cholesterol relatively in the type 5 patients. But probably the most important distinction between these is actually based upon the ApoB level. And you can classify patients based upon their atherosclerosis risk based upon their ApoB. Type 2A patients, which are the classic just high LDL normal triglyceride patients, like you might see with familial hypercholesterolemia, have very high ApoB levels. Similarly, the syndrome of familial combined hyperlipidemia have high LDL and VLDL and very high ApoB levels and probably higher cardiovascular risk than our FH patients with just high LDL cholesterol. Whereas our patients with the highest triglycerides, those type 1 patients with, familial chylomicronemia syndrome, actually have pretty low atherosclerotic risk and very low ApoB levels, even though their triglycerides are in the several thousands most of the time. So that's why I find this table useful to characterize our patients, because it makes me concentrate on which lipoprotein is abnormal, what their ApoB is, and that helps me think about who's at risk for atherosclerotic risk. However, you don't actually get which lipoprotein is abnormal based upon the levels, but you can plug in numbers into a web-based app. So Alan Snyderman and his colleagues put together a beautiful app. This used to be available on your phone, but if you go to apob.app, you can get it on your desktop. It's just not available on phones anymore. And if you know the ApoB and you know the cholesterol and you know the triglyceride numbers, which are very easy to get, then you plug those numbers in, and the app tells you which lipoprotein is likely to be in excess. It tells you what the typical primary causes of that phenomena are. Like in this case, it's telling us that our patient has high levels of VLDL and that it's consistent with a diagnosis of familial hypertriglyceridemia or these other primary syndromes. And it may be associated with secondary causes like you see here. So it's a very useful way to characterize our patients and a useful tool that I reference on a regular basis. Okay. So the other thing I think a lot about, and I'm going to ask you to think about at least for the next 20 minutes or so, is mechanisms. Because I think if you understand the mechanisms, you can think things through, and it's not quite as rote when you're managing care for patients. And if you can think it through, then you're not stuck with having to memorize algorithms and things like that, which I find very difficult. I know this is a busy slide, but I think it's something that you've seen before in different levels. So it's the slide that talks about how lipoproteins are, their typical physiologic mechanisms. And so remember that chylomicrons are those massive, buoyant lipoproteins. They're made in the intestinal tract. And the principal factor that drives chylomicron synthesis is actually dietary fat. So, and that's fat of all kinds. And so once chylomicrons are produced, they're dumped into the lymphatics so that they can then bypass the portal circulation. They find their way from the lymphatics up to the thoracic duct and then dump into the superior vena cava so that they don't have a first pass phenomena having to be metabolized by the liver. Out in the circulation, chylomicrons then will interact with the principal regulatory enzyme called lipoprotein lipase. That's what LPL stands for. Lipoprotein lipase is the principal triglyceride regulating enzyme, and it's expressed particularly in adipose tissue, skeletal muscle, and cardiac myocyte tissue, tissues that have very high energy requirements. And it's expressed bound to the endothelial surface, and it sort of dangles into the capillary lumen like a fishnet waiting for lipoproteins to come by. And it's a basically unstable protein that needs it to occur in sort of a dimeric form, and it requires multiple promoters and antagonists to really get it working most efficiently. And so these lipoprotein lipase will interact with a triglyceride-rich lipoprotein and hydrolyze fatty acids into the tissues that have high demand for the fatty acids. So when you're storing fat, you'll store it in adipose tissue because of lipoprotein lipase activity. And if you're using energy, like with your skeletal muscles, you'll utilize the fatty acids to drive your skeletal muscle use and cardiac myocyte at all times. And the net impact is that your chylomicrons get converted to remnant particles. And those remnant particles, that remnant particle conversion state happens very rapidly after eating, in less than a half hour or so. But then the remnant clearance takes place over several hours, and chylomicrons take at least 6 hours from the time of eating a meal to really clear those remnant particles by way of the hepatic cell surface receptors. If you have a defect in lipoprotein lipase activity, then chylomicrons will back up and your triglyceride levels will be massive, and that promotes acute pancreatitis. The only way to really impact chylomicron synthesis is to reduce fat. So it's the dietary fat, and it's not good fat, bad fat like we talk about with atherosclerosis, but it's all fats. So cheeseburgers, avocados, and salmon all raise chylomicrons. That's how fat is delivered. Fatty acids are delivered from the intestine to the rest of the body. So all fats will raise chylomicron levels. All right, so the remnant particles are a consequence of the metabolism of chylomicrons, and some people actually have a defect in the normal clearance mechanism. And if you have a buildup of remnant particles, even from chylomicrons, the remnant particles are small enough to generate atherosclerosis. So chylomicron remnants are atherogenic, even though chylomicrons themselves are not. So that's the chylomicron end of it, the exogenous pathway. What about the endogenous pathway? This is all run through VLDL. So VLDL is the lipoprotein that's made by hepatocytes in response also to fat within the cell. But because ApoB and cholesterol and phospholipids, the other components of VLDL and some of the apolipoproteins, are all pretty much fixed in state within the hepatocyte. So the main driver of VLDL synthesis is actually fatty acid availability. Unlike chylomicrons in the gut, however, dietary fat only contributes a small amount, and that's really dietary fat that comes back to the liver by way of chylomicron remnants. Other things that will drive fat within the hepatocyte and drive VLDL synthesis is dietary fructose. In particular, but any endogenous sugar as well. So it's not just fructose, but it's principally fructose, and that drives what's known as de novo lipogenesis. So fructose in particular will really drive de novo lipogenesis, increase fatty acids within the hepatocyte, and drive VLDL production. Another source for fatty acids in VLDL synthesis is the insulin resistance that occurs as a consequence of dietary fructose and fat in the liver. But you get a hydrolysis of fatty acids from adipocytes, and it drives fatty acids back to the liver along with glycerol that drives blood sugar up as part of the insulin resistance syndrome. And so the normal clearance of VLDL follows the same pathway as chylomicron clearance, but its remnant particles are referred to as IDL and, of course, LDL. and there's normal clearance mechanisms for them. And when you have impaired clearance of the VLDL remnant particles, those are highly atherogenic. And so they really participate in the process in a much more significant way. There's a ton of different regulators for all these things, but I really just wanted to highlight ApoC3 and ANGPTL3 because those are regulators that you're going to hear more about in the next few years because there's pharmacotherapy directed at inhibiting both ApoC3 and ANGPTL3. And I'm not going to go through all the details of this, but these are important regulators of this whole process, both from the synthesis perspective, also from the fatty acid hydrolysis, and the metabolism and clearance of these particles, and even the potential atherogenicity. So we know that individuals who have lower expression of ApoC3 tend to have lower coronary artery disease risk, and this is seen in large Mendelian randomization studies and just observationally that ApoC3 expression reduces CAD risk. We know that in large GWAS studies that there's a net impact of having loss of function mutation in ApoC3 that is associated with lower coronary artery disease and atherosclerotic cardiovascular risk. So it looks like it probably is a good target, both functionally, observationally, and from an inheritance perspective. One other aspect of the lipoprotein physiology that I think is worth mentioning with regard to triglycerides is CETP activity. So some of you may recall the last decade, CETP inhibitors were all the rage, and then they seemed to fizzle out. But understanding CETP is important for understanding triglyceride physiology and the phenotypes that we see. So individuals who have high levels of triglyceride, particularly just using as an example here, increased VLDL, will have increased levels of CETP expression and CETP activity. It's a circulating protein, a circulating enzyme that's responsible for the interaction between triglyceride-rich and triglyceride-poor lipoprotein, shown here LDL and HDL, representing the triglyceride-poor. So CETP acts as a protein that regulates the stoichiometric one-to-one transfer of triglycerides for cholesterol ester. So you get for every triglyceride molecule that gets donated, there's a receipt of a cholesterol ester. And so you get a modulation of the lipid content of all of the lipoproteins when CETP is activated. So LDL particles become triglyceride rich and cholesterol poor. They can then pass through the circulation, dump their triglycerides when they interact with lipoprotein lipase. Now they're just cholesterol poor LDL particles, also known as small LDL. The same thing happens with HDL particles, but HDL particles are smaller to begin with, and these particles are so small that they can actually be cleared by the kidneys. So you not only have reductions in HDL cholesterol, you have reductions in HDL particle numbers. So that kind of change is what's expected when you have high triglycerides. And the Danish group actually looked at a large population database from Denmark, over 70,000 patients, and when they looked at the impact on lipoprotein cholesterol content, you can see that as triglycerides go up from left to right, so each bar represents a range of triglyceride in the population, that the bars get bigger as you go. Of course, total cholesterol goes up as triglycerides go up, but it doesn't go up proportionally. And what's happening is that you're seeing a reduction in the HDL cholesterol. It's shown as the green bar. As you get higher levels of triglycerides, your HDL cholesterol goes down. The LDL cholesterol can stay the same or be even a little bit lower. And what's accounting for the higher total cholesterol is that there's higher remnant cholesterol present in people with high triglycerides. So it's the remnant cholesterol that goes up. Let me just take a drink of water. So again, triglyceride-rich lipoproteins lead to these diseases that we're interested in. And again, the Danish population distribution of triglycerides is shown here from that same database that I just showed you. And about, in their database from the last decade, what they saw is about 28% of the population has levels above 175 milligrams per deciliter. And that what you tend to think of in terms of high triglycerides is that the ASCVD risk starts to increase as triglyceride levels go up, but then it starts to thin out as you get to be very high triglyceride levels. So once you get up into the 1,000 milligram per deciliter range, the risk for coronary disease actually goes down as opposed to going up. Whereas the risk for acute pancreatitis is proportional and linear. The higher the triglyceride, the higher the risk for acute pancreatitis. We know that in general populations that the risk for acute pancreatitis, if you just have moderate hypertriglyceridemia, is at least 15 times the general population. Whereas if you get to severe hypertriglyceridemia, like in the 1,000+ range, your risk is going to be more than 50 times that of the general population. And then if you have a monogenic cause of that, like lipoprotein lipase deficiency or familial chylomicronemia syndrome, now you're talking a greater than in the hundreds times risk, or greater than 300 times risk. Probably the thing that causes acute pancreatitis is that these triglyceride-rich lipoproteins, especially chylomicrons, as they pass through the capillary bed, are exposed to ambient levels of lipase within pancreatic cells, and that you get initially you just get small release of free fatty acids from the chylomicrons because of that exposure. But the free fatty acids actually trigger within the pancreatic cells trypsin activation, and that trypsin activation, then you start getting pancreatic autodigestion. And once you start autodigesting the pancreas, now you're releasing all kinds of pancreatic enzymes, especially more lipase. So as long as triglyceride levels remain high or chylomicronemia persists, now you have persistent activation, and this just cycles on itself until you shut off the fuel source, which is reducing the level of triglycerides in the blood. And that happens in our patients when you make them NPL. Of course, you stop making chylomicrons. And with atherosclerosis, I think it's worth thinking about the physiology that's going on there too. So I'm sure you're familiar with how LDL particles contribute to atherosclerosis. They refer to it as the response to retention hypothesis, but the same happens with triglyceride-rich lipoprotein remnants that are less than 70 nanometers. They tend to pass as a direct mechanism to generate atherosclerosis. They pass from the lumen into the subendothelial space where they're trapped. Once trapped, ApoB containing lipoproteins are then susceptible to modification, oxidation typically, recognized by macrophage and converted to, and that macrophage, once it swallows that ApoB containing lipoprotein whole, becomes a foam cell. And once you have foam cell initiation, that's the beginning of atherosclerosis. And that this process is generated by a lot of different inputs, but the building block for it are the ApoB containing lipoproteins. So LDL particles for sure, but also all these triglyceride-rich lipoprotein remnants that are able to pass into the subendothelial space. There's indirect mechanisms too, because triglyceride-rich lipoproteins are loaded with triglycerides, and when exposed to endothelial lipase and lipoprotein lipase on the endothelium, then you get release of fatty acids, which actually have a pro-inflammatory response to the endothelium and promote atherosclerosis in that respect. And finally, there's this bystander phenomena. So you don't just have high triglycerides, you typically have insulin resistance as well, and hypertension and smoking and all kinds of other things that tend to go along with it. And so our high triglyceride patients tend to have lots of different inputs that are going on and driving this process. We know that high triglycerides are an important promoter of atherosclerosis, but we also know that the genes that regulate remnant cholesterol are important. And observationally, just people who have high levels of remnant cholesterol are at higher atherosclerotic cardiovascular risk, and also the genes that cause high remnant levels are associated with that. So we have strong indication that that there's an important impact from those remnant particles. Similarly, when you look at the genes that regulate triglyceride levels, not only do you see increased observational evidence, but there's genome-wide association studies that demonstrate that there's a relationship between the genes and cardiovascular risk. I showed you the ApoC3 evidence before. All right, so you have high triglycerides. Should they be treated? Bård Nordesgaard, who's Danish, who actually helped put together some of the Danish data that I showed you before, has reviewed all of the guidelines really going back to 1984 from the US and Europe and elsewhere, and reviewed them for the preceding 30 years and found some consistency and some inconsistency. With regards to treatment of triglycerides at the severe range to prevent acute pancreatitis, from the first set of guidelines to the present, there's been a unanimous decision that yes, triglyceride levels should be treated to reduce the risk of acute pancreatitis, and it gets a full green box there on the far right. Similarly, from the first guideline to the current, we attack LDL cholesterol to reduce ASCVD risk. That's the other green box there in the middle. We've gone flip-flopped a little bit with regards to low HDL cholesterol for ASCVD risk. While low HDL cholesterol is a marker of ASCVD risk, it's not necessarily a target. And most of the time, the guidelines have said, no, low HDL cholesterol should not be a target for therapy. But a couple of times there were, you may remember some times where we were treating low HDL cholesterol. And then finally, the more controversial is, what do we do with our patients with mild to moderately elevated triglycerides? And we've gone back and forth. It gets an orange box here. Sometimes we were told, yes, you should treat that. Sometimes we're told, no, you shouldn't treat it. And so where are we now? Well, if we're going to treat it, we know we have at our disposal diet, alcohol reduction, weight loss, physical activity, and we got some medicines. Sometimes we use plasmapheresis. And in Europe, they had the potential to use gene therapy for lipoprotein lipase in extreme circumstances. Maybe we'll have gene therapy or gene editing sometime in the future. There are current guidelines, both from Europe and from the US. The guidelines recapitulated an algorithm from the 2011 hypertriglyceridemia guidelines that suggested a sort of stepwise approach. First, assessing non-lifestyle secondary causes and lifestyle practices, emphasizing a healthy diet, and then varying the amount of macronutrients in your diet, especially fat in your diet, based upon the level of triglyceride. So the more triglyceride you have, the more likely you are to have chylomicrons in circulation. And that's where you should actually start reducing the fat in your diet, as well as focusing on other aspects of diet to maintain healthy lifestyle. Now, some of our patients have monogenic disorders, do not have any obesity, are not overweight. They just have a pure genetic disorder. So I give it an asterisk to remind everyone that not everybody with high triglycerides needs to lose weight, but almost everybody does. So, you know, the stepwise approach is really important. So knowing what the secondary causes of hypertriglyceridemia is very important. I made this a much more readable graph than what came from the document, and I highlighted the most important secondary causes of high triglycerides: poorly controlled diabetes, and then the inflammatory diseases like rheumatoid arthritis, psoriasis, lupus. Things in the lifestyle that bear highlighting: alcohol is the big one, sugar, especially sugar containing fructose, and sedentary lifestyle are huge contributors to high triglycerides. The medicines we all use regularly can have an impact. Beta blockers and thiazide loop diuretics can raise triglycerides. So can estrogens. And if you're at a transplant center, or if you take care of a lot of patients with immunologic disease, of course, immune modulating therapy can have a big impact as well. And then probably the biggest one, that, you know, overweight and obesity and the presence of insulin resistance and metabolic syndrome are huge contributors to people who have high triglycerides, and focusing on therapy for those conditions is critical. Pregnancy can be a real complicated time to manage hypertriglyceridemia as well. What can you expect when you help people make lifestyle interventions? Well, the ACC group actually have demonstrated data that suggests that you can lose up to 70% of your triglycerides with aggressive weight loss strategies in most of our patients. And dietary changes can enable 70% reduction, up to 70% reductions or more in triglycerides as well. Whereas physical activity and exercise, you tend to have a more modest impact on triglycerides, but important nonetheless. So this is their dietary summary. I think it's a little more complicated, but I like to think about it as like things to avoid, things to add, and some other sort of recommendations. One, very simply, don't drink any sweetened beverages. Very simple. Don't do it. What about sugar-free this or sugar-free that? Just don't. If you must, it's okay. But sugar-free is better than sweetened with sugar or some other caloric sweetener. But it's better. You're better off sort of training your palate to drink without sweetener. And reducing or eliminating ultra-processed food is the other sort of big thing to avoid. but minimizing alcohol, minimizing sweets, reducing starchy foods, especially packaged sliced bread that's shelf ready for 3 to 4 weeks at a time without going stale. Those heavily preserved products are very bad. Don't deep fry, and in certain circumstances, paying attention to the macronutrients is worthwhile. It's smart to eat more veg. Go out of your way to eat more fiber and eat all the colors. I think that's one of the ways that you know that you're getting fresh foods, whole foods, and foods that aren't colored with artificial color, but actual natural colors is what I should say there. Eating fish instead of land animals is probably better. Nuts, seeds, legumes. Olive oil should be your principal oil for cooking. So simple, basic recommendations that you can all do, even in a busy clinic. Makes sense to make your own food. If you're eating a lot at restaurants or food on the go, then you're not going to be eating. You're not going to be following these rules of dietary management. Drinking water before indulging can help mitigate some of the metabolic effects, and eat together, because we know that if you socialize when you eat, you actually have better lifetime outcomes than if you eat alone, like many of us are doing at our desks during lunchtime to listen to a lecture. Our therapeutics are basically statins and fibrates and omega-3s. There's very little role for nicotinic acid derivatives in this day and age. And remember, when we're treating the non-HDL cholesterol, we're treating LDL cholesterol and triglyceride-rich lipoprotein cholesterol levels. And the non-HDL or remnant cholesterol, in addition to the LDL, has the same evidence of data that the LDL cholesterol does. You may be familiar with the cholesterol treatment trialist linear regression analysis that showed that there's a proportional risk reduction for cardiovascular disease from statins and LDL cholesterol alone. Well, the same evidence comes if you look at non-HDL cholesterol, including statins, fibrates, niacin, even, and omega-3s. But statins make up the bulk of the evidence, and so they are the foundation of our care for ASCVD risk reduction. You're probably familiar with the Reduce It trial by now. It's a landmark clinical trial that showed some fantastic evidence for the benefits of high-dose omega-3s in patients with established ASCVD or diabetes with risk factors for ASCVD who also have moderately high triglycerides. And compared to the mineral oil placebo, high-dose EPA clearly reduced cardiovascular risk. So that set the tone for other clinical trials that were going on around the same time, but that were delayed by about a year or two after. So the Strength trial and the Prominent trial tested similar types of population using different therapeutics that affect triglycerides. So the Strength trial was also an EPA-rich omega-3 derivative at around a 3-to-1 ratio of EPA and DHA at that high dose, was stopped due to futility because it didn't show any of the benefits. Prominent was Pima fibrate, so a fibric acid derivative used in a similar type of population, added to baseline, background statin therapy and other therapeutics for people at high risk, did not show any benefits and was stopped due to futility also. And so how do you reconcile the Reduce It data in light of the Strength and Prominent? And most, I still think there's still some issues that are up in the air, but for sure, it's not a slam dunk as to what is the full explanation for this. But I can tell you it's not the triglyceride lowering. That I feel pretty certain of. So in the last few minutes, I'm just going to blaze through the current guideline strategies for dealing with this. And the ACC expert consensus decision pathway breaks it down into 4 different treatment groups. So those with clinical ASCVD, diabetes, moderate and severe hypertriglyceridemia. So individuals with clinical ASCVD and moderate hypertriglyceridemia, first step, optimize LDL cholesterol, then add EPA. It's really quite that simple. Our diabetic patients with moderate hypertriglyceridemia, first step, optimize LDL cholesterol, then add EPA. Pretty simple. For our patients who don't have ASCVD or diabetes, but who have the same moderate hypertriglyceridemia, use risk estimators. And I'll leave it to the group to figure out what the best risk estimator they have at their disposal. But if you're going to treat them with anything, it's going to be a statin-based regimen. You're not focusing on fixing the triglyceride, you're focusing on the risk. The only rationale for treating them with medicine will be to affect risk. And so that's an individual decision based upon what you think their risk should be. In patients with severe hypertriglyceridemia, levels over 1,000, fix the underlying problems, use a fibrate and or omega-3 fatty acid-based regimen to bring the triglycerides down to more reasonable levels, then use statins on top of that for additional triglyceride lowering to keep them out of harm's way, keep them as free of risk from acute pancreatitis. For those individuals with more moderate hypertriglyceridemia, between 500 and 1,000, but at lower ASCVD risk, you're basically going to focus on the triglycerides to keep them out of harm's way from acute pancreatitis. But if you think their risk is high and they're in that range, then it's going to be statins first, then triglyceride lowering second. We have a few things on the horizon, perhaps other uses for PCSK9 inhibitors for ASCVD risk reduction, even in patients with high triglycerides. There's an available drug called evinacumab that's available for homozygous familial hypercholesterolemia. We might have access to that for expanded indications as clinical trials go forward. I think we can take pemafibrate off the list since that didn't seem to help in clinical trials. We have a new CETP inhibitor that's pretty far along in investigation. Yes, that class of drug is not dead. We have therapeutics for ApoC3, others for ANGPTL3, and we have another HDL therapeutic that's marching along. And don't count out gene editing as something that we're going to be doing at some point in the future as we go forward. So I'll conclude just by reminding us that the rationale for paying attention to triglycerides, again, is to reduce risk for acute pancreatitis and ASCVD. Don't forget that these patients have other medical conditions, and that's really what your primary goal is managing their care. But in terms of paying attention to the triglyceride level, it's reducing their risk for acute pancreatitis or ASCVD, depending on where they stand at their levels. So I came right up to the edge of the time or beyond the time, but and I'm okay taking time to answer questions if there are any. If you're okay with that, Leandro.
Yeah, for sure. Thank you so much. What an amazing lecture.
Thank you.
I love in particular all the physiology that you always bring to the lectures and the outstanding slides.
By the way, not everybody loves that. I impose that on people who are willing to listen to me because I love it, and I'm glad you do too. And for those who don't, my apologies. It's just how I like to think in those terms because I think it helps me just understand what's happening. And I tell you, my patients, I think they enjoy it. I talk to them about it, and they like hearing about the physiology. I don't go into that kind of detail with them, but I draw that picture all day long to my patients.
Oh, I think it was great. If you have any questions, please put it in the QA. I'll start with one question. I love how you brought the importance of checking ApoB. And we know there's some differences between, for example, pemafibrate and IPE in the effects they have on ApoB. How should we use ApoB in these patients with intermediate hypertriglyceridemia? Can that help us decide what we use for treatment?
Yeah. So I was kind of hoping that one of my most important tasks as incoming president of the National Lipid Association was going to be to champion ApoB primarily. Like I really thought that I was going to use that pulpit and focus just on that. It turns out that people around the country don't even check LDL cholesterol. So we've had to regroup. Our group is actually focusing on just the basics because by and large around the country, our colleagues are not even doing the basics. And I'm sorry to say that, but that seems to be the case. So we're gonna be spending our energy mostly on just the fundamentals. But I will tell you, I don't think you'll ever go wrong measuring an ApoB because it will help you clarify that with a much more precise and useful tool, the atherogenic potential for your patients. It's the same as for LDL cholesterol. The lower, the better with regards to ApoB. In patients with very high triglycerides and low ApoB, that's more consistent with chylomicronemia. And if you're trying to affect chylomicrons, you're talking about a different diet than if you're trying to affect VLDL. So chylomicrons are made by the gut. If you want to lower chylomicrons, eat less fat. If you're trying to lower VLDL, you need to attack aspects of insulin resistance and weight loss and weight management. It's not always cut and dry. Like you can have high chylomicrons and VLDL, in which case it's primarily weight loss is going to drive this process. But ApoB is very useful for making the diagnosis and affirming the diagnosis. In our clinic, we see some pretty wild lipid cases. So establishing who has familial chylomicronemia syndrome or familial dysbeta lipoproteinemia, they're unusual and rare diseases, but you need to be able to make that diagnosis properly.
I'm certainly very excited for you to be the president of the NLA, and in particular in this time with the, we're trying to bring back the LDL measurement as a quality metric. So yeah. That's great, I think.
Yeah.
What do you define? I think there's no questions. I'll ask one more. What do we define as high ApoB? And I know there's a statement from NLA, or what do we call high?
Well, the 2018 AHA-ACC multi-society guideline, actually, they used a threshold of 130 milligrams per deciliter as indicative of a risk-enhancing factor. Alan Snyderman and his group, when they looked at inherited and severe lipid disorders, they found a threshold of 120 milligrams per deciliter as really being a marker of familial hypercholesterolemia or familial combined hyperlipidemia. And I think that most of the data would suggest that a lower threshold like that is really consistent. In terms of when you're treating patients, remember that as a standard, if you remember the Odyssey outcome trial with alirocumab, they used as an inclusion criteria participation. If you had an LDL cholesterol greater than 70, or a non-HDL cholesterol greater than 100, or an ApoB greater than 80 milligrams per deciliter as a threshold for introducing their PCSK9 inhibitor. So I think at the lower end, if you're wondering, I wonder if we need to do more, and the LDL cholesterol and non-HDL cholesterol, you're not sure, an ApoB over 80 milligrams per deciliter should prompt you to do more.
And do you think that's because of the Lp(a) as well there, or?
No, even when Lpa is high, it doesn't really contribute much to ApoB. It's there, even in people, except at the extremely low LDL cholesterol levels. So individuals with very low LDL cholesterol and very high Lpa, now you're talking Lpa will contribute a more significant percentage. But until you're in that kind of range, the predominant ApoB containing lipoprotein in circulation is always going to be LDL. So it's always LDL.
Thank you. We have a question from Jonathan Bradlow, one of our cardiologists. He brings the issue of the mineral oil as a placebo at the REDUCE-IT trial. Do you have concerns about that, and does it affect the validity of the trial?
Yeah, my wife is a social worker, and generally my go-to person for any time I have a hard question to ask, and she introduces common sense every single time. And she has taught me the rule that if something seems too good to be true, it probably is. So don't ever believe anything that seems too good to be true. The REDUCE-IT trial stands alone as this beacon of hope that high-dose EPA is going to be a very important therapeutic, but it stands alone amongst we were all very disappointed with the results of the STRENGTH trial. I expect, that's a high-dose EPA also, and yet they didn't see the same benefits. So I'm not sure exactly why that is, but it could just be that the placebo had of mineral oil in the REDUCE-IT trial raised risk enough to really move the needle in that trial. But I don't think that's the case. I think mineral oil probably played a little bit of role in the robust benefit of icosapent ethyl, but I don't think it explains the whole thing. And I'm not satisfied with it. I know it's sort of an equivocal answer. Yeah, I think it's a real thing, but I don't think it's a major issue. And I think there's so much strong evidence for the benefits of icosapent ethyl biologically, with angiographically, and outcomes-wise that I think it's still a worthwhile therapeutic. But could turn out to be wrong in the next 5 years if we have more data that refutes that.
Thank you very much. Another question from Jay, one of our cardiologists. If the patients with elevated triglycerides are willing to do only one, if you had to recommend just one lifestyle change, what would you focus on? Is it alcohol or avoiding highly processed food? What would you focus on?
I guess it depends which. I would assess which one is the one you think has the most bang for the buck. But alcohol is huge, but fructose has the same impact as alcohol. So I've been seeing this guy, a patient of mine, for over a decade, and I don't know how we haven't talked about it much, but it was only a few months ago that he said, do you think that liter of Coca-Cola I drink every single day is contributing to my problems? And I was like, oh my God, I'm such an idiot. How have I been seeing him all these years? And I mean, I've done like all kinds of liver tests on him to figure out why his liver enzymes were always elevated and triglycerides persistently elevated. And I did not appreciate how much soda he was drinking. And sure enough, he cut out the soda and everything normalized.
And I think we'll finish with one last question from Hussein. He says, what's the treatment for ApoB? Is there one main treatment for pharmacological treatment?
Yeah, anything that increases LDL receptor expression. Statins, ezetimibe, PCSK9 inhibition, bempedoic acid, bile acid sequestrants.
Many of them, yeah.
Yeah, and they're proportional. So statins and PCSK9 inhibition do it better, but the other therapies also help. It's clearance. It's that you improve clearance of it. It's not, you're not changing synthesis of ApoB, you're clearance. There was a drug that inhibited ApoB synthesis, and it's no longer available. It was only FDA approved for homozygous FH, and when you inhibit ApoB synthesis, then you get fatty liver, and we don't want to exacerbate fatty liver in our society.
Thank you so much. I always learn so much from you every time I hear your lectures. So
thanks, Leandro. I really appreciate you having me here, and I'm so glad that you chose a lipid topic for your grand rounds, and I hope everybody appreciated the opportunity too. So thank you.
Okay, thanks a lot, and good luck this year with NLA.
Thank you.